Difficulty swallowing intro. When a patient says they are having difficulty swallowing, they may be referring to one or a combination of the following symptoms. Dysphagia, which means food is unable to pass through smoothly or get stuck. Odonophagia, which means that swallowing is painful. Reflux and regurgitation, which means food or gastric secretions come back into the throat or mouth. Aspiration, in which the food or drink goes down the trachea instead of the esophagus. This can further lead to aspiration pneumonia. Gagging, in which patient may feel that the food is causing them to throw up and vomit. Globus pharyngeus, a feeling of a lump in the throat. Xerostomia, it means dry mouth, which may itself lead to dysphagia or odonophagia. Our main goal in this presentation is to discuss an approach to a patient with dysphagia, its relevant history and workup, and what are the main differentials and some general management options for dysphagia. Many specialists have to deal with patients of dysphagia, such as otorhinolaryngologists, gastroenterologists, speech therapists, dentists, internists, and geriatricians, to name a few. Dysphagia is a fairly common cause of morbidity in the elderly population. The swallowing mechanism. Let's begin by reviewing the physiology of the swallowing mechanism. It is generally divided into three phases. Oral phase, in which the food is chewed and lubricated to form a bolus. Pharyngeal phase, in which the movements of the soft palate, larynx, and epiglottis separate the air passage from the food passage so that food and drink are not aspirated into the nose or trachea. Esophageal phase, in which the food passes down the esophagus via peristalsis into the stomach. A disruption in any one of these phases could result in dysphagia, and difficulty in the pharyngeal phase especially could lead to aspiration. Classification of dysphagia. Dysphagia is classified according to site, whether it is oropharyngeal or esophageal, and the type of disorder, whether it is a structural disorder or a motility or propulsive disorder. The differential diagnosis for dysphagia could also be divided according to the cause: congenital, infections, trauma, inflammatory, autoimmune, neoplastic, neurological, motility disorders, iatrogenic, and mechanical causes. History and workup. So as you have seen, a multitude of conditions can cause dysphagia. When a patient presents with difficulty swallowing, here are a few important points to consider in taking the patient's history. Is it true dysphagia, or other related problem like odonophagia, etc.? What is the onset and duration? Any coughing or airway issues, to check for aspiration? Is it continuous, worsening, or intermittent? What is the location? Is it oropharyngeal or esophageal dysphagia? Is it more for solid food or liquids? Is there associated regurgitation or reflux? Does the patient have pain, weight loss, and/or dehydration? This is to assess the general condition of the patient. Examination. Oral and throat examination should be done, but the main way to assess dysphagia is to ask the patient to swallow solid food and liquids in front of you. Investigations. We shall start with baseline investigations. Chest X-ray can give us a quick and rough idea about the esophagus, but more importantly, it gives an idea about any aspiration pneumonia. X-ray neck, antero-posterior and lateral view, can give a quick and rough idea about the pharynx, larynx, and upper esophagus. If a neck pathology is suspected to cause dysphagia, CT scan or MRI may also be advised. Complete blood count, urea, and electrolytes can give an idea about the patient's condition. E.g., does he/she have any electrolyte disturbance due to dehydration? The investigations specific for dysphagia are fiber optic direct laryngoscopy, which can view the laryngeal inlet and is useful for investigating patients of oropharyngeal dysphagia. Barium swallow, in which patient is given a radio-opaque contrast to drink, and the contrast is then X-rayed as it passes through the pharynx and esophagus. Video fluoroscopy is similar to barium swallow, but instead of still images, a video clip is made of the contrast passage into the stomach. It is considered a better study than barium swallow. Esophageal endoscopy. This is particularly useful in patients with esophageal dysphagia, in which a structural lesion is suspected. Esophageal manometry. In this test, a catheter is passed into the esophagus, which measures the pressure along the length of the esophagus. This is useful in patients in which a motility/propulsive cause of dysphagia is suspected. Management of dysphagia. Obviously, the specific management of dysphagia depends on the underlying disease. In general, here are the key points while managing a patient of dysphagia. Ensure adequate hydration and replenish any deficit electrolytes, such as sodium and potassium. Patients are usually malnourished and feeding can be started via nasogastric tube. If NG tube cannot be passed, then total parenteral nutrition via IV route might be needed. Patient might require feeding jejunostomy or gastrostomy for long-term feeding. Food consistency variation and diet modification might help some patient with dysphagia due to motility disorder, especially geriatric and stroke patients. Swallow positioning and pharyngo-esophageal exercises are also useful. Reduce aspiration risk by regular swallowing assessment, patient's positioning and airway protection measures. Oral hygiene with use of mouthwashes. Proton pump inhibitors, like omeprazole, might reduce the severity of discomfort of dysphagia. Antibiotics will reduce infection, especially in patients with increased risk of aspiration.